Hello guys, welcome back to my YouTube channel Maniac Medico, and this video is going to be in continuation to the previous video, that is with pharmacology. So previously we learned about pharmacokinetics, that is what the body does to the drugs, that is absorption, distribution, redistribution, excretion. Now here we will understand once the drug is entered the systemic circulation, what the drug is bringing about, what the changes the drug brings to our body. We will learn about that in a very simplified way. So dynamics, what does it say? That what the drug does to the body. So what can a drug do to the body? It brings about a physiological change. It can change the mechanism. What is physiology? Basically it is the mechanism on which the body works. So it can bring about changes in the physiology or biochemical mechanism, like suppose a drug which can act on our any pathways, which can inhibit Krebs cycle or various other pathways in the body, oxidative phosphorylation or there are many biochemical pathways. The drug which can inhibit that, or it can bring about a mechanical change and it can bring a action onto the body. So what else we can say about it is there is few examples. So we'll study about certain examples, and also yes, very interesting question what everybody has is, like suppose a patient comes to you and complaining that I have a headache. So you prescribe him a simple drug, acetaminophen or aspirin, any drug which can relieve pain, or any NSAID, right, piroxicam, that can also aid headache. So it definitely comes to their mind that how does the drug know that it has to act on the area of pain. So it is simply related to the receptors, which we will study in details. There are like many receptors like adrenoreceptors, muscarinic, nicotinic, and various other receptors present in the body, and always the drug goes to its target organ where the receptors are present. So we prescribe drug in such a way that it always goes to the target, like of the area of the pain. It is not like if somebody is having a pain in the headache, we'll give a drug which is related to the pain in the bones. It is not like that. So let's continue with our topic. So the first example is adrenaline interacts with adrenoreceptors and causes cardiac stimulation. So what can adrenaline do? Adrenaline can increase the heart rate. It can split glucose, that is glycolysis. The end result is we need energy. So adrenaline also, we also know that we have learnt in our 11th and 12th, it's also called as the fight, flight or fright hormone. So it basically provides energy. What happens is it dilates your pupils, it increases your heart rate, it redirects the blood from the GI tract so that the body can work more efficiently, right? We need energy at that time. So this is what adrenaline does. It brings about certain changes. It has alpha receptors and it has beta receptors. We will discuss it later when we study about adrenergic receptors. Now, mechanism of drug action. Drug can bring physical, chemical changes in a cell. Example, laxative alters the surface tension. So what is laxatives? Laxatives are certain drugs which are given to patients who suffer with constipation, in simple words. So what it does is it reduces the surface tension over there. It makes the stool more firm. So it is bringing about a physical and a chemical change. Hence, the patient can defecate without any pain or any uneasiness caused. That's what happens in constipation. The motion is too dry. So this lubricates the motion, simple way. Majority of drug produce effect by interacting with target biomolecules, that is proteins and enzymes. So like I told you, the drugs always act on the target. So what is the target? Target can be a protein, right? What does the protein do? The protein forms an enzyme. It codes for an enzyme. So the drug will bring about a change in an enzyme, or it can also affect the ion channels. Like we have L-type channels and T-type channels, which regulate the calcium, right? And also we have sodium potassium channels, they also which are responsible for the nervous reflex, and also the calcium channels for the heart and the muscle conduction. Then it can affect certain transporters, like there are many transporters in our body, like IP3DAG pathway is one of them, is a classic example. So it can alter the transporters, right? And the other one can be your receptors. So there are certain receptors present for everything on our cell. So they can alter the receptor. Either they can close the gates for the receptor or open it so that the drug can either bind to it or cannot bind to it. And it can bring about a change or no. So enzymes. So what does it say? Drug can either increase or decrease the rate of enzyme mediated reactions. So if you prescribe a certain drug for a person having peptic ulcers, right? So what do? Our end goal is to reduce the secretion of pepsin and HCl. So what can the drug do? The drug will decrease the amount of HCl produced by the patient. Or if a patient is suffering from, suppose, hypoglycemia, he has less blood sugar. So we can give him adrenaline in order to increase his blood sugar level. So what is the drug doing here? It is increasing the breakdown of glucose. In simple words, a drug can either increase the activity of enzyme or suppress it, right? Or we can take another example like Tylenol. It's a very famous medicine, and it is given to patients who have thyroid problems. That is, they are deficient, those who suffer from hypothyroidism. So what happens is that this drug adds up to the thyroxine, which hence helps their metabolism and various processes. And another example is, as I told you, adrenaline stimulates hepatic glycogen phosphorylation. As I told you, it helps the breakdown of glucose. Or physostigmine competes with acetylcholine for cholinesterase. Okay, fine. So cholinesterase is an enzyme which degrades acetylcholine, right? So physostigmine, it is also an adrenergic drug. Cholinergic drug. What happens is we use this in cases of glaucoma. Okay, so this can compete with acetylcholine. Now let's talk about the various mechanisms through which a drug can work. So one of them is competitive inhibition. Like the name says, the drug competes with the actual substrate. So as we know, every enzyme, if this is an enzyme, let's call it E, and it has a substrate, let's call it S. So what happens in an ideal situation is, every time the substrate goes and binds to the enzyme's active site, it forms an enzyme substrate complex. So E plus S gives rise to enzyme substrate complex, right? But we also know that there is other site other than the active site. So if this is the active site of this enzyme, there is another site in this enzyme, which is also called as the allosteric site, other than any site other than the active site. So what can this do? Either it can compete for the active site in the competitive inhibition, or in the non-competitive it will go bind to the allosteric site other than the competitive site. Okay, alright, so let's continue. So drug competes with the substrate for active site. So here what happens is Kmax of the enzyme increases and the Vmax remains constant. We might have studied in the graph the constants. In biochemistry also you might know it. So what we need to do over here is, we need to increase the number of substrates so that we can at least reach Vmax of the enzyme. So for the enzyme to reach its half of its maximum value, we need to increase the substrate. Logistically, we need to increase the substrate because what has happened is the active site is not free. So what happens in this case, again, like I showed you with this diagram, it's a lock and key mechanism. So if suppose this is the drug D, which was over here, and this is the substrate S, right? So what I need to do is, I need to keep adding substrates more. So what happens is this drug gets exhausted and this substrate can happily go bind to this, right? So this is what happens in competitive inhibition. So as the name suggests, there is competition for the active site, right? Now in this also there is equilibrium type and non-equilibrium type. So let's study the non-equilibrium type since it is important to understand. So drug binds to other site other than the active site, forms a covalent bond. So what is a covalent bond? We have two types of bond. We have ionic bond and we have covalent bond. So ionic bond is complete transfer of electrons, whereas covalent bond is what? Sharing the pair of electrons. In simple chemistry, that's how we understand it. So what happens is OP or organophosphates, okay? So what they do is they bind to the esteric site of the enzyme cholinesterase. Like I told you, cholinesterase is an enzyme responsible for the degradation of acetylcholine. Now what happens if it goes and binds to the esteric site of the cholinesterase enzyme? So there is no more breakage of acetylcholine is coming and getting accumulated. So as we know, it is an active neurotransmitter, it will cause more and more of stimulation. So in organophosphate poisoning, we use the drugs called as PAM and DAM. Just note it for now, and I will explain it to you in the next chapter when we study about organophosphates in detail. So PAM and DAM, and another drug we use is oxime. We use oxime. So oxime is basically used to free the cholinesterase from the esteric side, whereas PAM and DAM, what happens is this can also affect the NM type of receptors. So in order to get rid from the nicotinic action, we use PAM and DAM. They are the two drugs, and we also use various oximes. So these are the drugs used to treat organophosphate poisoning. Now if you would be wondering what is organophosphate, so As the name suggests, they are phosphates, organic phosphate substances. They are found in various other chemical pesticides or industrial chemicals, and this what happens is they can just be applied on your skin and you can get the poisoning. So they are very dangerous substances, hence has to be used carefully. These cases can be seen in chemical factory workers or even farmers. And there is, yes. So what happens over here is the Kmax increases and Vmax decreases. So what happens is no matter how many of our substrates we add, the enzyme cannot attain its maximum value, right? We need to give a competitive inhibitor over here in order to stop the reaction. So what this says is, let's take an example. Methotrexate. It has 50,000 times increased affinity for dihydroxyfolate reductase, right? So if methotrexate has, it's supposed to be binding to its substrate X. But what happens if I induce dihydroxyfolate reductase? It has 50,000 times more affinity to it. So simple words, it will go bind to it, and we don't see the desired action which has to be brought by the drug. Let's study about receptors. So what is a receptor? Binding site located inside or on the surface of effector cell that initiates a response. So if this is a cell, let's say if this is a cell, and let's say this is acetylcholine receptors. So what happens when acetylcholine is coming here, ACH, what happens? This will bring out certain changes in the cell. Maybe this is chemical, at the chemical synapse there can be some change. Suppose acetylcholine brings about some change here, it enters the cell and the signal is delivered, whatever the action has to be performed, right? Maybe this happens in the CNS. So, and yes, so this will bring about certain change. That is what is happening in the receptor. The specific substrate or the drug, it goes binds to the receptor which is located inside or on the surface. So this is a surface receptor. There are certain receptors which are located inside. They are more close to the nucleus, if I have to be specific, and they initiate certain response in the cell. Which type of response can it be? It can be physiological, biochemical, physical, or chemical. Any sort of response can be attained. So with this, we have understood the very basic of how a drug works. Now let's learn about certain terms which are very important for us. So what is an agonist? What is an inverse agonist? What is an antagonist? What is a partial antagonist? Right? So what is an agonist? So here what is happening is this prefers the drug to go and show its action. It is a preferred drug, right? So drug binds to a receptor that brings about a pharmacological action. So suppose we need a desired change in a patient, right? We want to sedate a patient, or we want him to get rid of his pain, right? So what we do, we give him an agonist. So for example, opioids, they are CNS depressants, so hence it is depressing the CNS, and yeah, what happens is his pain is reduced. So this is basically aiding the action of the drug. So this has an intrinsic activity of 1. Examples are adrenaline and histamine. So what is intrinsic activity? Measure of drug to induce functional change in a receptor. It can lie between 0 to 1. It is all or none. Either it will happen or it will not happen, in simple words. So agonist always prefers the drug to go and do its action, right? Now let's study about inverse agonist. What does an agonist do? It prefers the action of a drug. The inverse agonist, as the name suggests, it will do the opposite of it. So opposite to the agonist. Example is GABA. It is a depressant, as we know. It is a depressing neurotransmitter. So this has an intrinsic activity of 0 or -1, because minus is indicated because it is stopping the action, right? Plus is indicated when we are getting some good sign from the drug. Minus is indicated when we are getting a negative sign. Next is partially, okay fine. Some of them, some of the inverse agonists, right, they can be partially active in its basal state, right, when there is an absence of an antagonist. So we'll study about antagonist, but please note down, this is important, that certain inverse agonists, they are partially active in basal state. Like when their antagonist is absent. Antagonist is something which opposes the action of an agonist. So we are here at antagonist now. Drug which prevent the pharmacological action. So suppose you have given a patient certain drug like opioids, and he has started to abuse it. The patient is taking too much of opioids, because we know they are habit forming drugs, right? So the patient starts to abuse the drug. So what do? He has a case of poisoning after certain time. So what we are doing is, we'll give him become an antagonist which stops the mechanism of the reaction. So agonist, what happens? The agonist will go, it will open the receptor for it, make the drug easily enter or bring about the change. So antagonist, what happens is it goes and it blocks the receptor so that the drug cannot go inside. So naloxone is the chemical antagonist of opioids. If somebody asks you what is the physiological antagonist of opioids, so let me tell you, it's atropine. Physiological is atropine, and physical, if somebody asks you what is the physical antagonist of naloxone, so it is simple, activated charcoal. It is activated charcoal powder. So what does the activated charcoal is doing when we give them this powder? It is basically for gastric lavage. So whenever we are giving this powder, as we know, it has the property to adsorb. It can adsorb on it. And the opioids will be out. Next is a partial antagonist, an agent which activates a receptor to produce submaximal effect but antagonizes the action of a full agonist. So what it does is it can bring about certain changes, but what is it doing? It is producing submaximal effect but antagonizes the action of a full agonist. So if I give a drug X, it is supposed to go and act on receptor R, but there is a partial agonist present. It will antagonize it. It will antagonize it. So it will act against it, right? So if I took, and it has an interesting activity of again 0 to 1, similar to a agonist which has an activity of 1. So the example is dichloroisoproterenol. And one more thing I forgot to mention was a competitive agonist. So what it does, it has an intrinsic activity of 0. It competes basically. It competes with the substrate and it produces a certain pharmacological action. Example to that is propranolol and atropine. Atropine, as I told you, it is an drug used in the CNS stimulation, and propranolol, it is a beta blocker. And this is competitive antagonist. This is a competitive antagonist. It competes. So atropine basically acts on your muscarinic receptors, right? It is an antagonist for muscarine. And propranolol, it acts as a beta blocker. It is a non-selective beta blocker which can act on both beta 1 and beta 2 adrenergic receptors, right? Let's move ahead. So we have certain receptors like ion channels, like I have mentioned, like the L-type receptors. So there are 2 types, okay, in the receptors also. One is ligand gated in the ionic channel receptors. One is ligand gated, one is G protein coupled. Here we can see IP3DAG, inositol trisphosphate. DAG you might have studied, and there is ligand gated. So ligand gated cationic receptor. Example of this is nicotinic receptors, right? And the other ones are G protein regulators, such as beta 1 adrenergic receptor or receptors for certain calcium channels. Now let's study about certain more terms which can help you simplify what is agonist, how will a inverse agonist act, and how does the drug act. So affinity. What is affinity? Drug receptor associated. So suppose a drug X is present and there is drug Y. Now if I say X has let's say X has a higher affinity, greater would be a bit this thing. X has a higher affinity compared to Y. So what happens is, at a given time, when we check for the pharmacological action, the drug X is able to produce a better response compared to drug Y for the same equivalent weight of drugs given. So we can say that drug number X is more efficacious. So it can show a better action. So this depends on drug receptor association. So how good a drug can bind to its receptor? If a drug can bind very easily to the receptor, definitely it has a very higher affinity compared to some other drug, which is Y in our case. So high affinity, same number of DRS will be formed at lower drug concentration. So what this says is, suppose even if this drug and this drug, right, like I told, X has a greater affinity compared to Y. So when we give the drug X even in a lower concentration compared to Y, yet I will get better results compared to Y drug, because X has a higher affinity compared to Y. Generally we compare it with the same molecular weight, but even if it is given in a lower dose, the X acts better. And one more term we can learn over here is bioequivalence. Bioequivalence. So what happens, what this says is, for the same given weight, right? For the same given weight of drug, the drug for the equal weights and which is showing a greater tendency to act. So the drug, suppose let's take an example of sodium valproate. This is an anti-epileptic drug, and let's say another drug, suppose of sodium valproate itself. But the catch is here. Suppose this is manufactured by Sun Pharma, and this is manufactured by, suppose, let's say Cipla. So guys, don't think that I have been paid by Sun Pharma or Cipla to promote their drugs. It is just an example so that we can understand it better. These drugs are used in India. So what happens is, suppose a person is consuming sodium valproate, but one is consuming of Sun Pharma, the other is consuming for Cipla. So somebody goes to the pharmacy and says, I want a drug of sodium valproate from Sun Pharma, but unfortunately they don't have the drug. They say, please use Cipla. And what happens is, though the drug has the same molecular weight, same chemical used in it, but for a reason, the drug of Sun Pharma is better suited to the patient, or in general, the drug of Sun Pharma works better compared to Cipla. So what will happen now? The patient will consume it. What is the drug supposed to do? It prevents the firing effect of the neuron, right? Adjacent firing effect of the neuron. These drugs are used in grand mal and petit mal. Basically, they are the types of seizures. We can use them in various types, like tonic-clonic seizures or many other. When we will learn it when we will study about epilepsy. So what happens is, this drug is supposed to prevent epilepsy, but the patient took Cipla. It had less efficiency, though for the same weight. The term bioequivalence is used here because they have the same weight, but the drug of Sun Pharma is more efficient compared to the drug of Cipla. So what happens is, the patient starts to get an attack of seizures. So the doctor asks him, did you take your medicine on time? Or did you take the prescribed medicine? So the patient says, yes, I took sodium valproate because the same drug was given to the patient by the pharmacy guy. But what happened over here was, this drug of Sun Pharma had a greater efficacy or affinity compared to the drug of Cipla, because this has a greater ability to bind to the receptor. So this is a small example, and again, this is not any promotion, just making it clear. So that's the concept about affinity. I have told you about intrinsic activity already, I suppose, but still we will discuss it again. So intrinsic activity is measure of drug to induce functional change in a receptor. So what happens is, if the drug is gone to the receptor, is it bringing a functional change? Is the drug receptor complex being formed or no? So simple, drug plus receptor. It is in reversible reactions. Yes, if I remove the drug, the receptor will stop to function. So is it forming the drug receptor complex or no? Simple way. So if yes, the drug has a higher intrinsic activity. If not, it has a 0. So it is all or none, either 0 or 1. Next is potency, the amount of drug in relation to its efficacy. Example, if weight to weight drug A has higher efficacy than B, A is potent. So again, in the concept of bioequivalence, I told you about potency also and efficacy also. So what happens here is, 1 mg of butanamide is equal to 50 mg of furosemide, right? So you can see that there's almost a difference of 49 milligrams, or I could say 49 doses. So definitely we will always prefer the drug which is greatly potent, which is highly efficacy, which has a good intrinsic activity, and which is more affinity to the drug receptor complex, right? So this is all for dynamics, and we'll study about certain more things such as therapeutic index, or probably therapeutic index we will study, and also about adverse drug effects. There are various types like idiosyncrasy, and there can be teratogenic effects. We will study about this in a while. Hello guys, welcome to the third part of this video, and today we'll be studying about adverse drug effects. So what is an adverse drug effect? Suppose there is a drug X which causes an undesired, unwanted effect, so we call this as an adverse drug effect. So what happens over here is, other than the desired or the known pharmacological effects, if we get to see certain other drug effects, we call this an adverse drug effect. So we have basically two criteria. There is adverse drug effect and there is adverse drug reaction. So we'll study about this in detail. Let's first start our study with what is therapeutic index. So suppose a drug A, okay, it shows good results in 50% of the population, whereas for the rest 50% of the population the drug is toxic. So what do? We say, how do we find out for the therapeutic index of the drug? That is, TI is TD 50 by ED 50, that is the toxic dose upon the effective dose in 50% of the population. So we get to know what is the therapeutic index of the drug. And let's start with adverse drug reaction. So what does this say? Response to a drug that is noxious or occurs at a dose used for therapy. Suppose let's take an example of laxatives. We use it for constipation. Suppose we have given the drug to a person and the person is continuously using the drug. It has cured his constipation, but there is an added chance that he might get diarrhea also, because the stool becomes smooth from very firm. So this is an adverse drug reaction. We know these are the chances. Whereas adverse drug effect is an unwanted drug effect which we don't expect when we use the drug. So it is a very unwanted effect and we don't know about it. As in, we know about it, but it is not expected to take place because it is not a known side effect of the drug to the patient. So very classical example is antibiotics such as penicillin. So before giving penicillin or any antibiotic, they just ask you, are you allergic to it? Why? If not, if you don't know, always if you don't know what you think, you should tell no, because it can be life threatening, right? And cause anaphylaxis and various other things. So they give you a small injection on the surface of your skin and they circle that spot. If this bump becomes bigger and red and there is pain at that side, that means you are allergic to penicillin. If there is nothing, then penicillin can be used to it for your treatment. So antibiotics is a classic example of adverse drug effect. Now let's study about various type of drug reactions which can take place. So one of them is idiosyncrasy. So what happens is, due to genetical abnormality, a drug causes an effect in certain population. The effect can be bad or good. Generally it is bad. So what happens is, chloramphenicol, it is a drug and this can cause aplastic anemia. So it is not that this drug will cause any adverse effect in other people, but in this person, because he had a genetic abnormality. This can be anything. Another thing is teratogenic. What happens is, during pregnancy, suppose if the mother is abusing alcohol, so we get to see alcohol fetal syndrome, that is microcephaly, or various other symptoms are present in this. So what happens is teratogenic. So alcohol can be one of them, or even anti-epileptic drugs. They can also cause teratogenesis. That is why, this is the reason why many drugs are not prescribed during pregnancy, because it can have an effect on the child. Even paracetamol is also given very carefully in case of fever. There is no chance of giving antibiotics. So we can say that teratogenic can cause idiosyncrasy, because the mother used to take opioids or alcohol. The baby had a genetic abnormality and he can show idiosyncrasy. Next is mutagenic. So mutagenic is due to consumption of any chemical mutagens, maybe in case of known or unknown. In case of radiomedicines for the treatment of cancer, this is very common. Carcinogens, we know consumption of primary or secondary carcinogens such as tobacco, very abused, or cigarettes, acetates of tobacco. So these can also have some adverse reaction. Now let's study about tolerance, when the body has developed resistance. Example, antidepressants. So SSRI is nothing but specific serotonin reuptake inhibitors. So what happens is, these drugs prevent the reuptake of 5-hydroxytryptophan, which is nothing but the serotonin which we have in our body. So these drugs can develop tolerance. That is, suppose a patient is showing effect to a drug X up to 2 weeks, but the patient continues this drug for a longer time. So what will happen is, the body has developed a tolerance, so we cannot use this drug. We can use some SNRI in that case, serotonin noradrenaline reuptake inhibitors. We will study about this also later. Next is tachyphylaxis. So what happens is, Suppose a patient has taken a drug X. When he consumes the drug, there is action, but immediately the action diminishes, right? So that is what is tachyphylaxis, rapid diminution in response of drug and its effect. Example is nitrate. So nitrates is a drug used in case of angina or chest pain, right? And this can also happen in case of certain cardiac glycosides. They are also used for the same purpose. So they can develop tachyphylaxis. That is, they have an action and then after some time, boom, there is no action of the drug. Then there is dependence. As we all know, addicts can happen in case of opioids, benzodiazepams, and these are the habit-forming drugs. So there is dependence. So the patient, when we stop the drug, he will have withdrawal symptoms, right? So this is about dependence. Now let's study about hypersensitive reaction. So according to the Gelcombe classification, we have 4 types of hypersensitive reaction. One is the immediate. We also call it the anaphylactic, which is very quick. Let's study about some pathophysiology of this. What happens over here is IgE comes from the mast cells. So whenever there is an allergen A introduced in the body, if this is the mast cell, what happens? This causes the degranulation. The mast cell breaks. It has certain biological active substances, BAS, which we know as histamine, serotonin. These cause inflammation, redness. So we also refer it to as urticaria. So we can see the classic 5 signs of allergy over here. That is calor, rubor, dolor, tumor, functionaless. So that is heat, pain, swelling, loss of function, and redness. Right? These are the 5 classical signs of an immediate allergy or an anaphylactic reaction. This can be life-threatening. This can cause many things. Various BAS like kallikrein, bradykinin, or Hageman factors are activated. Then even the echinocinates, inhalation factors are activated. These cause release of huge amount of histamines and serotonin. The patient can even have a serotoninergic shock or the serotonin syndrome. These all are life-threatening reactions. This can lead to even edema, asphyxia, and various other things. And even also, it's a very life-threatening condition. And one of the classical examples I told you is because of antibiotics such as penicillin. Next is the cytotoxic. So what happens over here is cytotoxic immunoglobulins such as IgG and M are activated. Here what happens is this is also in case of acute allergy this happens. And here what happens is the cytotoxic IgG and IgM, they are circulating. So what happens, the antibodies are in the free state over here, and they also cause an allergic reaction, right, to us. This is about cytotoxic. What happens next is, what I wanted to tell was the first 3, right? The first 3. These are humoral, that is B cell mediated, and this is cellular. To be specific, T killer cells. I tell you about it. So next one is the immune complex mediated. So what happens over here is the IgG and IgM are involved. So here an antigen antibody complex is formed, right? So what happens? These go and form microprecipitates. So what do I mean by microprecipitates? They form a sticky substance. They go and stick to the basement layer of the cell, right? It can cause various problems like hemostasis and various other problems, which can lead to various diseases like pulmonary edema is one of them, right? So again, this is a fatal condition. This is immune complex mediated. Here the antigen antibody complex is formed, and here what happens is the antigen is in the free state. Next is the delayed hypersensitive reaction, or we say that it is cellular mediated by T cells. So one of the classical example I can give you is graft rejection. Graft rejection. So whenever an organ is transplanted, yes, definitely it is in foreign body to us, and we all know that T killer cells are responsible for this. They basically rule out any foreign particles present, and this is not related to humoral but to cellular. So graft rejection is one of the examples. The other one can be contact dermatitis. Right now, certain people have contact dermatitis with certain chemicals used in your soaps, so they cannot use soaps or any other such substances. Right, so what happens over here is this is not seen immediately. It's not like we've put an organ and then it immediately is rejected by the body. No, it's seen over a course of time. That is why it is called as a delayed hypersensitivity. Even contact dermatitis, it is seen 1 or 2 days later. But in case of immediate reaction, like within few seconds or few minutes, you can see the reaction taking place. There will be redness all over the body. There will be spots, everything. And we need to give some anti-allergic drugs, and even for some time, even some symptomatic treatments are also needed. In case of graft rejection, what is happening is we have grafted an organ from a donor. We check for the MHC, everything, but yet it is a foreign particle. So what happens is this key T killer cells, they start to accumulate around the organ and they produce cytotoxins, which over the time they kill the grafted organ. So what do we do here? We give some immunosuppressants, right? We give some immunosuppressants, like we can increase steroids, in specific corticosteroids we can increase, right? And we can even also use cyclosporins, yes. So these are the immunosuppressants used in order to prevent graft rejection, and when a graft is rejected, this is a delayed type of hypersensitive reaction, even contact dermatitis in soaps. So with this, these are the adverse drug effects which can happen. When we study about pathophysiology, we will focus on these 4 reactions. Like I told you, these 4 have a huge effect, like various activating factors such as bradykinin, kallikrein, Hageman factor. They activate various certain factors which in turn release some biologically active substances. We will learn what is biologically active substances like prostaglandins, interleukins, serotonin, histamines. Everything is released. It is a cascade of reactions in case of allergy. And yes, it is a very interesting reaction, and these reactions, it is terminated by eosinophils. We will see in which case there is a high count of eosinophils, where there is more number of granulocytes, where there is more number of mast cells, and various other things. In the first 3, yes, of course. And over here we see how the T cells act on the various organs, and how they destroy it, and how we can control them. We can also talk about the HIV virus over here when it comes about T cells. And for now, yes, these are the various type of adverse drug effects. And if you like the video, make sure you give a thumbs up, and please do subscribe to my channel. And also you can ask your questions in the comment section, and yes, you can demand for the notes also related to this topic. I can give it to you if needed. And for further videos, stay tuned, do subscribe, and thank you. That's all for today. Have a nice day. Thank you.